Thank you.
Yes.
So I go ahead. All very familiar faces. Glad to see you all, and really happy that all of you are safe. Your near and dear ones are safe, and hopefully we get on and get to see each other very, very soon. Now the slide movement. He's done something to my, okay. So no financial disclosures. So angle evaluation is key to glaucoma diagnosis and management. And gonioscopy is our current reference standard. It basically involves the visual inspection of angle structures. However, gonioscopy is fraught with a few issues such as subjectivity, the way we record our findings, and a significant amount of training and expertise which is required to do a good gonioscopy. This is where cross-sectional angle imaging tools have made an impact on our clinical approach and practice. Some of these tools are the ultrasound biomicroscopy and the optical coherence-based platforms. There's the AIOC2021-Topic-IC178-DR.ARUN, the high-definition OCT, and the SWAP source OCT. Ultrasound biomicroscopy has been a revolutionary technology. It's essentially based on a high-frequency ultrasound B-scan system and delivers very high-resolution images of the anterior chamber and the angle, and especially of the retroiridial space. Until today, there's no other imaging tool that can image the retroiridial space as well as the ultrasound biomicroscope. Now, this really enhanced our knowledge and application in terms of understanding glaucoma better. One important aspect of using or making sense of the ultrasound biomicroscope is the need to identify the scleral spur, which is the most important landmark, and then go on orienting yourself with regard to the angle status. So in terms of once we have identified the scleral spur, any iris contact anterior to the scleral spur to the angle wall represents angle closure or iridotrabecular contact and essentially means angle closure. So overall, the UBM has played an important role in refining and strengthening our concepts. The ability to image the elusive iris ciliary body complex has allowed us to come up with diagnoses that have been challenging and definitely has helped us modify approach to therapy. Concepts such as relative pupillary block, pigment dispersion syndrome, and plateau iris, as well as aqueous misdirection was better understood. Now, in a situation such as this, iridociliasis can be pretty challenging to diagnose, and an UBM makes it easier. But however, rare diagnosis such as iridociliary tumor is something that only the UBM can give you. In terms of a clinical scenario like this, the clinical diagnosis is fairly straightforward when it's a lens-induced angle closure. However, the UBM adds additional information such as zonular status, and that helps you plan your surgery better, plan the approach better, and eventually have a better outcome. And in a case like this, information about the anterior chamber, the status of the lens, and zonules will definitely help you plan a better surgery, and eventually the patient will have a better outcome. Now, in terms of aqueous misdirection, the UBM has thrown significant light with regard to this aspect. We have recognized there's another entity called as the annular effusion syndrome that looks very much like aqueous misdirection syndrome. And we know that a surgical approach is required when there is when the supraciliary effusion is not present, whereas when the supraciliary effusion is present, a medical approach can be adopted to start with. In a situation like this, again, the status of the anterior chamber would help you decide what is going on with the patient and how to approach this surgically in terms of surgical planning and management of this patient. Moving on to the AIOC20, there have been several generations of this instrument, starting from the time domain platform, moving on to the spectral domain, and then the SWAP source. Essentially, the imaging has moved on from being a low resolution to a high resolution platform, and from being meridional to become circumferential. One of the first platforms we were exposed to is the low coherence interferometry, which had a spatial resolution of 10 to 20 microns. It is a non-contact technology done with the patient sitting up, and the image acquisition is rapid. The one disadvantage with this platform is the inability to image the retroiridial structures. And again, the most important aspect of making sense of an image from this OCT is to identify the scleral spur. This is essentially follows the similar principles as the UBM, a change in the curvature of the angle wall and a point of high reflectivity. And once you've identified it, angle wall contact of the iris anterior to the scleral spur represents angle closure, and the one below here is representative of an open angle. Now, the big question is, what is the consistency of visualizing the scleral spur? It can be as simple as this, or could be as complex as this, and though visually this appears to be an open angle, you're not able to conclusively say that you're located at the scleral spur. So this is the challenge, and the study from Singapore showed that in about 70% of the images, one is able to identify the scleral spur. Now, how does AIOC perform against gonioscopy? The study from Singapore, again involving about 203 patients, found that the sensitivity of this procedure, of this imaging tool, is about 98%, whereas the specificity is at about 55%. And what this essentially means is that 45% of the normal populations can still have false positive on the AIOC and would still need a gonioscopy to confirm closure. Now, the problem of the scleral spur and its definitions was considered, and it was thought that if you increase the resolution, maybe the imaging is likely to be better. And that's where the spectral domain OCT platforms and the Fourier domain OCT platforms came to the picture. However, what they found was they're able to definitely see structures better, but it does not mean that the scleral spur was seen better. We're able to identify structures such as the Schwalbe's line, the trabecular meshwork, the Schlemm's canal. And then what was noted in the analysis was that the structure that was seen most prominently was the Schwalbe's line, and the definition of the scleral spur continued to be around 79 to 80%, and still not good enough to be used widely. Circumferential imaging was another aspect of anterior chamber segment imaging, which was thought as something that was lacking, because what the prior AIOC technologies gave us was just a 10 to 20 microns of cross-section, whereas the swept source technology was able to overcome that and image nearly 360 degrees of the angle. The technology essentially images nearly 128 cross-sections, takes samples from all these areas, and you're able to summarize this using a semi-automated software using an index called as the iridotrabecular contact index. It's essentially a closed angle, means the ITC index is close to 100%. This essentially means 360 degree closure. The lower the ITC index, more open the angle is. Now, the AIOC on the whole has given us a broad overview and understanding about angle closure and parameters, and many novel parameters, some of which are the iris parameters, such as iris curvature, iris thickness, and iris area. All of these were noted to be associated with a greater amount of narrowing of the angles and associated with angle closure. What was noted from the Singapore team was that a greater iris curvature, a greater iris thickness, and iris area were significantly associated with the presence of narrow angles. Further, novel parameters such as anterior chamber width, anterior chamber, the lens vault, and all of these parameters had an association with angle closure. So essentially, the summary from what we gain from this is that angle closure glaucoma is not a homogeneous disease. The relative importance of each factor and anatomical factors may be different in different individuals. There may be many subtypes of angle closure according to the different anatomical factors, and individualized treatment is something that maybe we need to start considering. Now, this is a good time to take a step back. If you notice the cost of equipment that you're dealing with, the gonioscopy is as less as 8,000 rupees. And the AIOC gives you something like this. In comparison, the gonioscopy gives you information that is of greater detail. Now, this is something that we need to step back and look at and use the imaging technologies judiciously. So one other limitation of the imaging technology is the inability to do a dynamic assessment. And gonioscopy, you get these clues that are essentially help you understand pathology better and also help you prognosticate the likely effect of therapy. Now, on an AIOC, this is just a peripheral anterior synechia, whereas the core information is missing from this information. Now, is this primary or is this secondary? But gonioscopy can tell you this. Now, let us consider this example on the left. If an imaging scan line runs this area, what you get is essentially an open angle on the AIOC. And if it runs through this area, it's essentially a synechial or angle closure. Whereas when you do gonioscopy, the presence of a simultaneous open and open area of the angle as well as synechiae is clearly indicative of a diagnosis. And in this case, eye syndrome, when you tie it up with the other findings, a typical scalloped broad synechiae again is very, very typical of uveitis. And this, you know that which direction you need to head to when you do a gonioscopy. Again, you look at an example like this, the pattern of pigmentation on gonioscopy is straight away gives you a diagnosis, whereas on the ASOC, this is just an open angle. So what has imaging really added? It's an objective tool. It has helped control illumination-related influences and helps us visualize the iridociliary complex, and added great value in patient education, crucial information to understanding of angle closure in iris, plateau iris, misdirection, and supraciliary effusion. And it does have a significant clinical impact when used judiciously. Gonioscopy skill continue to be crucial and integral part of glaucoma management. We need to continue to learn gonioscopy and continue to practice gonioscopy. Thank you very much.